prolific surgeon from Gujarat, Dr. Shail Vasavada, and back-to-back AACRS AO film winners. So all to you, Shail. He'll be talking on the new generation patient-friendly Edof lenses.
Thank you so much, sir, for the kind introduction. We do receive research grant support from Alcon Laboratories. I think the biggest drawback or biggest reason why most surgeons hesitate to implant multifocal IOLs of any kind or any brand are that they are worried that which is going to be that one unhappy patient which is going to spoil their mood for the rest of the next few months. And therefore, everyone is looking at other options except for IOLs. However, I must say that with the newer generation trifocal IOLs, these symptoms are far less than what they used to be before. But not all patients are suitable for trifocal IOLs for various ocular and non-ocular reasons. However, all patients, irrespective of their background, rural, urban, they believe cataract surgery is their chance to be independent of glasses after the surgery is done. With increased life expectancy and with UPI and digital India, phones and smartphones and screens have taken over everywhere. So what is an Edof lens? So there are so many nomenclature, monofocal plus, pinhole, this, that, etc. So the FDA has made certain guidelines, and to simplify it in simple language, what it means is that an Edof lens must have at least more than one line improvement in intermediate and near vision compared to monofocal IOLs in more than 50% of eyes, and it should not be inferior to monofocal IOLs for distance vision. This is a very striking line to understand that when an IOL does not fulfill this criteria, so not even one line improvement in intermediate and near vision, they do not qualify as Edof lenses. So any IOL which is labeled as a so-called monofocal plus is not going to consistently give you more than one line improvement in intermediate and near vision in more than 50% of eyes. Otherwise, they would have got the label of Edof IOLs. And there have been now several articles in literature to suggest that the near vision is significantly better with the Edof IOLs compared to the monofocal plus IOLs. The advantage of Edof IOLs is that they are free from dysphotopsia and all the other issues related to it. The drawback, however, is that they are not the IOLs for someone who doesn't want any glasses. So they do need reading glasses, particularly for fine print. And there is a marginal loss of contrast in dim light, although it's not clinically significant with most platforms. So this is a 56-year-old male, a senior manager in a factory, a few kilometers. So Ahmedabad is very industrial, but it's outside the city, about 30 to 60 kilometers from Ahmedabad. He's myope, and his main concern is glare while night driving. He now has cataract. So his activities are, he needs supervision of field force as he's the manager. He checks daily logs, and he drives back to the city through country roads, which are single lane roads, no dividers, and therefore headlights. He wishes less dependence on glasses, but doesn't want to have compromise in driving back home and going for day on and day out. So glare and night driving being his primary concerns, trifocal IOLs were not suggested, and we suggested a bilateral Vivity with a target emetropia because driving is important for him. We explained that he will need glasses for fine print reading. Fortunately, he had an excellent outcome binocularly with a good binocular intermediate and near vision of N8 comfortable. When we stretch it with extra light, he does read N6 in the clinic. However, we do know that this is not the real life scenario of N6 with the extra light. He's able to drive comfortably on his own. That was his primary concern. He finds that his reading vision is fairly good, including he's increased the font size in his mobile. So he's able to manage that and the headlines basically of the newspapers. He does use glasses selectively while cross-checking bills and accounts and uses a 1.5 diopter reader for that. So in short, for night drivers, this is a good IOL. 64-year-old lady actively does stock market trading analysis on her desktop. Her husband is suffering from chronic illness and mainly bedridden. She is the one who's running the house, very well to do. Two children, both stay abroad. So she is taking care of the husband and the family. Cortical cataracts, keen on spectacle independence, but does not want to compromise on the quality of her vision, as she is the main person here in India running the house. So we discussed the option of bilateral Vivity toric as she had astigmatism. We said we'll target one eye for emetropia, and based on the outcome, let's see if we can do something for the other eye. So this was her first eye where we planned an IOL of 24 diopters, and fortunately she did turn out quite well for distance and quite good even for intermediate and near. In the second eye, normally I would have chosen a 22, but I bumped it up a little bit to 22.5, which is a minus 0.5 diopter target. She is now comfortable for almost all activities without glasses, distance, intermediate and near. We did our randomized clinical trial, which got recently published in JCRS, comparing two groups of bilateral emetropia and mini monovision only up to minus 0.5 diopter, not more than minus 0.75 diopter. And what we found was that the good part was the binocular distance visual acuity was not compromised even in the mini monovision group, and the intermediate and near vision was significantly better in the mini monovision group. However, we had equal number of patients who said they didn't need glasses in both groups. Coming to another case of a 73-year-old gentleman, bilateral cataract, retired but very active. On ocular examination, he has fine ERM and therefore not a good candidate for trifocal IOLs. And therefore, we suggested the option of an Edof IOL, keeping in mind the positives of less problems in the quality of vision with an Edof. We discussed the option of target emetropia for him, and he's very happy. He uses around 1.25 AD for fine printing. So even for fine macular pathologies, it's something to consider. An 83-year-old female, she's 8 months she stays in Canada, 4 months she comes to India, and in Canada obviously she's housebound. Addicted to iPad and Sudoku, and because of her nuclear cataracts, she's not had to use any reading glasses for the past several years. So demanding lady, very active. Unfortunately, on posterior segment examination, she has dry RMD and significant drusen. So that was a deterrent for us to suggest a trifocal IOL for her, because near vision was her main activity. So we discussed that unfortunately trifocals is not a good option. We'll consider bilateral vivity. You may need, we explained that you can use extra light on your iPad and otherwise, and you will need glasses for reading, and probably even for your iPad, we are not sure how it will turn out being dry RMD. Fortunately, she did very well, and she's N8 unaided for near binocularly, and she's able to manage all her iPad and her reading and games and Sudoku on the iPad without glasses, so she's extremely happy. So I think the Edof IOLs, the newer generation Vivity, with which I have good experience with, has a good quality of vision for definitely distance intermediate and very good functional near visual acuity for most daily tasks. It's been having shown to have good outcomes in healthy eyes, but I think now we have found that stretching the limits to mild comorbidities like early glaucoma, post-LASIK, ERMs, dry RMD, early dry RMD is something that is of use. Do explain to them that they will need reading aids for fine print. That's something that you cannot get away with in Edof IOLs. There is some loss of light for near activities, so if you ask them to increase particularly the contrast and brightness of their phones or tablets, that will really help them to be independent of glasses even for near. But it is not for those who don't want any glasses for reading. Maybe for them trifocals are the best IOLs. But this definitely stretches and increases the range of patients in which you can use presbyopia correction. Thank you so much for the patient listening.
Wonderful talk, Shail, and I would second that, yes, Vivity, specifically in Edof, are the lenses of choice in cases of comorbidities, except one post-hyperopic LASIK. I think that has been a very burning topic here. So I think, yes.